Hello, welcome back to Political Science 400-500C, Public Policy for Health Security and Resilience. My name is Nathan Myers, and this is a presentation for week 3 of the course, in which we're going to be talking about biosurveillance and data and how that plays into controlling a potential avian influenza pandemic and how it's being used in the current outbreak going on in the United States. We're also going to be looking at issues having to deal with supply chain concerns as they pertain to avian influenza and some other emergency operation issues pertaining to avian influenza as well. So we're going to start with the Katz and Moore chapter 5 outbreak data, which is available in the modules for the course. And this comes from a larger book called the Outbreak Atlas, which is written by Rebecca Katz and Samantha Moore. It's a very good resource if you're interested in anything having to do with dealing with pandemics, dealing with public health emergencies. We're going to be looking at a few other chapters from that book throughout the course, but if you find those chapters interesting, I would encourage you to seek out the book and have it as a resource for you. So in terms of particular information from this chapter, so we're going to talk about the different types of data that are collected for biosurveillance purposes. The first listed here is epidemiological or case data. This includes case numbers and counts used to calculate the incidence of a virus, the prevalence of a virus. So, a lot of that data that's being reported currently is infections in animal populations, chickens and other poultry, wildlife, as well as cattle. But of course, there's also data that's being reported as far as humans as well. Mortality and fatality data is obviously important, both in terms of animal populations and human populations. To what degree are infections proving to be fatal? It's not all strictly quantitative data, however. Qualitative data can also be collected on morbidity and mortality. So looking at, beyond the numbers, how are the effects of the virus, avian influenza or another virus, affecting individuals, affecting families, affecting communities? How are deaths in communities, whether animal related or human related, affecting communities? Obviously, there can be serious economic effects on the agricultural industry and farmers, and those kinds of effects should be looked at the human level, but obviously how they're affecting families and affecting communities at large. Quantitative data on disease incidence. Geographic data, obviously we're interested in the degree to which avian influenza or other virus outbreaks, are they widespread throughout the United States? Are they located in a particular region? In terms of the areas where they are being infected, how spread out are these cases? So we can get some better understanding of sort of the size of the problem and the degree to which it's a national problem versus a regional problem versus maybe a more local kind of issue. Contact tracing data. Obviously, contact tracing was something that was talked about a lot during the COVID-19 pandemic. There were efforts that, were perhaps more successful in some areas than others, but there were efforts, when infections were identified, sort of reaching out to the people that those infected with COVID-19 came in contact with and trying to get a sense of both where individuals originally contracted their infection and to whom they might have passed on the infection. So in the case of avian influenza, contact tracing is going to involve, for people who, in particular human beings who have contracted avian influenza, the first question is obviously, have they come in contact with poultry? Have they come in contact with any kind of wild game, wild birds, or cattle? Because if they haven't come into contact with any of these kind of standard disease vectors, then it raises the concerns of, is this a situation where there's a human-to-human transmission, which if that's going on, obviously we want to know about it as soon as possible. And then syndromic surveillance data, which can include, as noted there, things like school and workplace closures. If infections, rise to the point in a particular community where schools are having to close down because so many kids are in faculty and staff are out of school, or workplaces are having to shut down, that could be indicative of a major outbreak. Also, pharmaceutical data is often looked at. If there's a lot of people who are seeking out medications, dealing, with treating flu-like symptoms and things of that nature, that would also be data that the public health authorities and others would want to be aware of, to serve as an early warning that there could be a major threat. Humanitarian data is also applicable. So, this pertains not only to dealing with outbreaks, but just kind of dealing with public health in general, the level of food security and access to clean water in communities, because the more concerns there are in a community about these sort of basic necessities before an outbreak, before a health emergency, the more likely there is to be sort of widespread effects. Because if you have a community that already has risk factors already and is already vulnerable to health concerns before the outbreak occurs, when a virus gets into that community, there's more likely to be widespread and particularly negative effects. The security environment, to what degree, is there security in terms of housing security? Do people have adequate housing? Are these high crime areas? Those sorts of things come into play. Again, because if people are experiencing more vulnerabilities, whether they're economic vulnerabilities or whether they're social vulnerabilities, the less they may be able to reach out for help, or the less they may feel like they're able to reach out for help. And they may not be willing to talk to people in the public health sector or in the medical profession if somebody were to reach out to them. And then obviously population locations, we want to know where people are, where they're living, so that we know, again, if people are going to go to door, trying to get information from people, have you experienced any flu-like symptoms lately or anything like that? We know where to sort of concentrate our efforts if we know where the population is. Obviously, laboratory data, diagnostic tests, this again was a big issue during COVID-19. I'm sure all of us at some point, had to do the nasal swab to test ourselves, whether that was at home or whether it was at a pharmacy or a doctor's office. Most of us have probably done it multiple times at this point. But certainly once those diagnostic tests were available, it made a lot of things easier because there was a little bit less of a guessing game. Obviously, there were the at-home rapid tests versus the ones that were actually done at pharmacies where you had to wait, potentially a few days or even up to a week to get those results back. But at least there was a mechanism to test for whether people actually were infected or not. And this is going to be very important, if there's if at any point there's widespread human infection with avian influenza, this is going to be very important. But it's important now with monitoring
the agricultural livestock population as well as wild birds. We want people going out in the communities and doing environmental assays to test for the presence of the virus among wild birds. So, we want to collect as much applicable data as we can and run tests on it. So, we understand, where the virus is currently and have a better understanding of how it's spread. But we also obviously want to monitor for changes in the virus. Is it mutating? If it's avian influenza, is it mutating in a way that could potentially make it easier to transmit among human populations? Observational studies, clinical trials. This was, again, if we look back at COVID-19 with the different vaccines, conducting those trials to test for whether the vaccine was safe, whether it was effective, all of that was going on throughout 2020. And then once a vaccine or another type of treatment actually is released to the public, gathering data on the degree to which people are taking the vaccine or taking advantage of these other treatments, and looking at, are there different areas, some areas are taking it and other areas aren't, and how can we reach out to those people who are not utilizing the resource. Modeling studies, looking at different outbreak models and predictive models. And there were a lot of, if you look back at the COVID-19 pandemic, and if you Google, COVID-19 models or data models or something like that, there were a lot of different organizations that were trying to model for how significant the effect of COVID-19 was going to be on the United States. And they looked at, different scenarios, scenarios where there was more social distancing and more protective measures, scenarios where there were fewer protective measures, and trying to get a sense of, under different conditions, what level of infection can we expect to see, what level of fatality can we expect to see. And certainly, similar sorts of activities would take place if avian influenza were to become a major concern in the United States as well. And I'm sure if you search now, you can probably find some models looking at the effect on the agricultural industry, the effect on the human population. Avian influenza, as we've discussed previously, is something that's been around for a long time. It's been considered a risk to human beings for a long time. So I'm sure there's been a lot of different models that have been done over the years to evaluate what its effects would be. But, it can change. We were just talking about the fact viruses can mutate, viruses can change. And with those mutations comes changes to the models that we have to look at. Medical countermeasure data, access to medical countermeasures and outcomes from them. So the degree, gathering data on the degree to which vaccines have been distributed in different areas. Again, what was the uptake? What's been the result? Has it reduced mortality? Has it reduced infection? So you'd want to collect that data. And then it talks about non-case data. This is about things, like quantities and costs of laboratory materials, personal protective equipment, medical countermeasures, workforce, supply chain, secondary data impact. So, how has the outbreak, whether it's COVID-19 or avian influenza, how has it affected the ability to get these materials, the availability? How has it affected their cost? How has it affected the workforce? Have we seen a lot of people in the public health profession, the medical profession, becoming unavailable? How has it affected the supply chain, the economy at large? So all of those things were certainly talked about during COVID-19, and they'd be particularly relevant during an avian influenza pandemic as well, because avian influenza is potentially not just a major threat to humans, but it would also, as we have seen, can affect the food chain, can affect the supply of different types of foods. So we'd have to look at that kind of information as well. So in terms of data management, data are cleaned and aggregated in integrated digital data systems that pull from multiple data streams. So this idea of integrated data is very important. And integration of data can be challenging because, as I think we've talked about previously, like looking at electronic health records, there's been a long ongoing effort to try to make electronic health record systems better integrated, better able to communicate with each other, but it's still an ongoing challenge. And we continue to face that kind of challenge on multiple fronts. So integrated data, if it's available, can then be used to identify patterns and transmission dynamics, which allow health professionals to design evidence-based disease prevention and action plans. So again, ideally, we want our response to an outbreak or a pandemic to be evidence-based. And that was one of the major problems with COVID-19, especially in the early stages, was we really did not have good data because we weren't able to do large-scale testing throughout the United States. We didn't have good data about how the degree to which it was being transmitted and where it was being transmitted. So that led that hindered our ability to make evidence-based decisions, and arguably led to maybe we didn't have to do actions at the national level the way that we did them early on. Maybe we could have done more targeted interventions, but we just didn't have the data to know that. So flexible, interoperable data platforms and adequate, well-trained staff are critical to effective outbreak management. Integrating a multitude of data streams and types from many reporting channels can be challenging and thus requires coordination and well-structured data architecture and management. This is a big problem, even within the United States. If we're looking at the federal level, the state level, and the local level, this was recognized as an issue prior to COVID-19 and remains an issue after COVID-19. There were discussions about state health departments or local health departments faxing information into the federal government and things like that. Obviously not the most efficient way to transmit data that you can think of. So, we have challenges in our ability to share data between our levels of the federal government in the United States, which hinders our ability to create the kind of well-structured data management that this is talking about. So obviously, before the next major pandemic occurs, we would hope that significant improvements have taken place. It goes on to say, this requires protection of technology against data loss and unauthorized access, and determinations of acceptable equipment for use in the public health agency's internal network. So obviously, I think all of us have been affected by a data breach at some point in our lives. I've been affected by multiple data breaches at this point. My family's been affected. So this is obviously a concern across the government. And if you're collecting data involving particular individuals and involving people's health status and things like that, obviously that kind of data needs to be protected. Hopefully that data would be de-identified as much as possible. So if there was unauthorized access, people couldn't determine exactly what individual was being referred to and things like that. But we need to do as much as possible to bolster our systems against hacking. And then the determination of acceptable equipment for use in the internal network. There'd have to be discussions, for example, can people use their own personal cell phones to access the network, or would they need to use a particular business cell phone or another device that maybe has more security on it in order to access the network. An additional benefit of digital data management that also helps facilities downstream include the rapid dissemination of information across the various sectors involved in the prevention, detection, and response to outbreaks. So, you know, the benefit, one of the benefits of data management discussed here is the fact that, you know, the better system we have to collect the data, sort of organize the data, collate the data, analyze the data, the quicker we're going to be able to produce meaningful reports and meaningful updates that we can transmit to the local level, the state level, to various federal agencies, and keep people informed so that, you know, we're able to rapidly adjust to the situation and rapidly adjust our plans and take action when necessary. So the slower we are at collecting this data and analyzing the data, the slower we're going to be in using that data in ways that are going to be meaningful to the public. And obviously, if we're not doing that, the public is going to become more and more frustrated if all we can say is, well, everybody just, you know, keep social distancing, you know, schools will stay closed. But if you're not providing them any, you know, new information or new context for why that's going on, people are going to start to become disenchanted with the system. So it says, well-integrated public health, laboratory, clinical, humanitarian, and other data helps responders proactively identify outsized impacts on certain populations. So, you know, if it's, you know, particularly hitting the elderly hard, or if it's particularly hitting children hard, or people in the medical profession, our ability to bring these different data sources together will help us to determine that faster. Integrated analysis of geospatial data in particular can help both epidemiologists and humanitarian responders recognize patterns and plan logistics. So again, that geographic data, if we can determine, you know, what areas are being particularly hard hit, and then, you know, sort of looking in, you know, what are the characteristics of that area? You know, for example, if a particular area is hard hit by avian influenza, one of the factors could be that, well, there's a lot of homes or apartments in that area where multiple generations of a family are living together. You know, maybe it's particularly crowded and you have the elderly living with the young, and that may be driving the level of infection. So if you have that kind of information, that gives you at least the knowledge of what's going on, and maybe you're able to target some interventions to help manage that situation. Data ownership can be kind of a sticky question with this kind of information. The chapter says, yet given the various stakeholders, data may be owned by entities that might ask for data sharing agreements to ensure the data are only used for managing the outbreak. So, you know, this could come into play. You know, ownership of data has come into play at the international level with countries sharing data, because countries are concerned that they'll provide data to another country, and then that data will be used to produce new medications and vaccines. And then the country that the data was shared with are going to reap all of the economic benefits, and the country that originally had the data isn't going to see any of that benefit themselves. So internationally, it's an issue, but it can also be an issue for the sharing of data between the public sector and the private sector, or vice versa, or between, you know, research institutions and the public or private sector. So Unfortunately, these concerns about research and development and who's going to benefit economically from vaccines and pharmaceuticals. This is still an issue even during an ongoing pandemic or an ongoing outbreak. So we have to be cognizant of that and be ready to address those issues head on should they arise. In terms of publishing findings in a fast-moving outbreak, public websites, media outlets, and even social media can be used to share outbreak data. So, traditionally with scientific or academic publishing, there's a peer review process, and any articles that are published in academic journals or scientific journals, typically they have to go through a peer review process before they're shared with the public. But during COVID-19, you saw a lot of publications of what were called preprints, which is basically, the research was looked at by the editors. If the editors found that the data and the results were plausible and seemed to be something that would be of value to share with the public, that information then got disseminated through websites and online journals because there was the belief that during the pandemic, it was more important to get potentially useful information out as rapidly as possible, as opposed to adhering to the strict sort of peer review process. So there's still a certain level of questioning and controversy about that, because ideally we would want that kind of information to go through as much vetting as possible. But at the same time, if it's something that could potentially save somebody's life, if it could help to inform better medical treatment, you don't want to hold that back if it's possible to get it out. As far as data in the public, sharing key data with the public is an important part of keeping them educated, and part of the public health field's larger effort of making the public a larger part of the effort, a partner in outbreak response. Disease data published for the public often focuses on key descriptive data of an outbreak. So case numbers, fatality rates, location, risk factors displayed in a table or graph form. So again, the idea is if there's evidence available that seems like it is credible and it is potentially useful, if public health wants to engage the public in these efforts to control viruses, they're going to have to be willing to share this information rapidly. And I think, from COVID-19 and since COVID-19, it's become apparent that particularly the American public is sort of less willing to just kind of take instructions from the public health sector without seeing some actual evidence or seeing good rationales for doing so. So it's important as much as possible to provide data in real time to keep people informed and to say, this is what's going on in your community. These are the actions we need you to take to keep yourself safe, to keep your family safe, to keep your neighbors safe. So that's it. Excuse me. That's it as far as the information that I wanted to share from this chapter. If you have any questions, please feel free to send those to me through Canvas messages. Along the same lines, talking about biosurveillance and the importance of having good systems in place, I wanted to also look at this reading that again was provided in the modules. And this is a report that was issued by a group called the Bipartisan Commission on Biodefense. They've released a lot of these kinds of reports. They originally started working back in 2015, which was obviously pre-COVID. And their focus originally was preparing the United States for a bioterrorism incident. So an intentional release of a biological toxin against the American people. They're still concerned about that, but they've also, because of COVID-19, pivoted a little bit to focusing on naturally occurring outbreaks, kind of casting a wider net in terms of their focus. So back in 2021, they released this report, Saving Sisyphus, Advanced Biodetection for the 21st Century. And it's a pretty lengthy report, so obviously I'm not going to go through all of it. But I encourage you to look through it, because I think it has some interesting information, and it's good to be aware of, what kind of technology is currently available and what type of technology we ideally would have in the event of these kinds of situations. A lot of the commission's reports start off with kind of a scenario of an incident that could happen and what the response would be by federal, state, and local authorities as a result of that incident. So that's kind of how the report starts out. It has this scenario of an anthrax attack in the United States, which obviously we've experienced anthrax attacks previously back in 2001. But this is a more widespread case where there were 11 cities targeted, over 100,000 cases, and over 40,000 deaths. So this is a pretty severe kind of scenario that they're laying out in terms of the use of anthrax against the American people. So again, I'm not going to go into all the details, but I wanted to kind of touch on the elements that were going to be so kind of starting from the back to some degree, because I think this idea of the biodetection cycle is kind of important to think about. As if we're thinking about, from COVID-19 to avian influenza or whatever the next big event is going to be, we need to think about improving these systems to be able to detect emerging threats. Because without that detection, we're not going to be able to collect the data and we're not going to be able to respond effectively. So the idea of redefining the biodetection mission based on jurisdiction needs and threat information. So in terms of threat information, evaluating, if we're thinking about bioterrorism, looking at what terrorist groups or rogue nations may be developing, may intend to utilize, and sort of direct our efforts to dealing with those kinds of threats. Looking at the needs of different jurisdictions, different cities are going to have different kinds of risks. For example, not every city has a port. But those cities that do have ports are going to need the means by which they can monitor the shipments coming in to detect any potential danger there. Conduct a technology survey based on mission requirements. So again, looking at the technology that's currently available and the types of threats that we need to monitor for. And if there's a disconnect there, start developing new technology to address those disconnects. Develop prototypes for new types of technologies. Select and offer these technologies to the different jurisdictions. And then provide operational reachback and support for biodetection. So, providing the technology and then going back and helping the communities to evaluate how well is the system working, how could it be improved, and providing support for improving the systems. So this report deals a lot with a system called BioWatch, which is a system that was set up in multiple large cities throughout the United States. And the idea was that it would monitor the air in those cities for different types of toxins, including things like anthrax. And if samples were taken and there was found to be anthrax or some other toxin present, it would sound an alarm, and that would give the federal government and state and local authorities a heads up that they needed to take action, that there was some kind of active biological threat in place. Over the years, the system has been found to be pretty flawed in a lot of ways, and there's been a lot of push to improve it or replace it. But to do so would be pretty expensive and pretty time consuming. So it's something that has not proven to be a huge priority. And again, this is largely because this is focused on bioterrorism. And bioterrorism isn't considered as much of a risk as naturally occurring diseases or other types of terrorist threats. So it gives, kind of a decision tree of, whether or not to replace BioWatch. So questions that federal government authorities should be asking themselves to decide if BioWatch should be replaced or not. But I've read, a number of things about BioWatch, and the consensus definitely is that BioWatch should be replaced. If you look at the different technologies that are available and the degree to which they're successful on different metrics, you see at the bottom, BioWatch doesn't seem to check any of these boxes. It's not fast, it's not accurate, it doesn't help to attribute where the threat came from, it's not adaptable, it's not user-friendly, and BioWatch is only geared towards certain types of pathogens. It can't detect, the full range of potential threats that could be used. So from that metric or set of metrics, definitely BioWatch is lacking in a lot of areas. Kind of goes through a timeline of sort of how BioWatch has been evaluated and those kinds of things. So I won't, spend too much time getting into the weeds on this, but I think the key things to think about is that, we talked about the data aspect and the management of data and the sharing of data. And that data is only going to become available if we have systems in place to collect that data. And obviously with COVID-19 and with avian influenza, a lot of data got collected because people were showing up at hospitals or people were going to public health clinics or other things like that, and were being tested, and those samples were analyzed and so forth. We want to be able to detect the signals of an outbreak or the signals of a threat as quickly as possible. So the more systems we have in place to do that, and we've talked about things like syndromic surveillance. So monitoring, the amount of people who are showing up to emergency rooms with different symptoms, the amount of people who are showing up at pharmacies. Excuse me. The amount of people who are showing up at pharmacies and requesting drugs to deal with different, flu-like symptoms and things like that. So those can serve as an early warning system, but also these kinds of biodetection systems, if there's an intentional terrorist act especially, can be useful. So we want to have the best systems in place Because if we're dealing with something that is exploding all over the country, whether it's naturally occurring or whether it's a terrorist caused event, we want to become aware of it as quickly as possible so that we can take action as quickly as possible. And we want that action to be driven by data, by evidence. So we need that data collected rapidly, analyzed rapidly, and shared rapidly across the country. So I think that wraps it up for our discussion about outbreak data and biosurveillance. I hope you found this useful, both in terms of the assignment and in terms of your own interest in these questions. Before we go, I wanted to relate this to the discussion for this week. So the discussion for this week for week 3 talks about what advantages does your community have in regard to the collection of outbreak surveillance data. So looking at the community you've chosen, the city you've chosen, are there any sort of notable benefits or notable strengths that they have as far as collecting this type of data? What techniques or technology for outbreak surveillance should your community develop or improve upon? So again, thinking about kind of the nature of your community in terms of its characteristics, its geography. Like for example, I mentioned cities that have ports have particular concerns that other communities don't. So think about some characteristics that your community has that may not be an issue for other communities. With avian influenza, it might be, having a poultry processing plant in your community or a cattle processing plant in your community or something like that. So those are the questions related to biosurveillance that you should think about as you're going through the discussion. So hopefully you find that information from this was useful to answering those questions. And again, if you have any further questions you want to share, just let me know. Something else I wanted to note as well that I haven't noted previously is also in the modules, there's a link for current news articles regarding avian influenza. So I have the MPA program has a LinkedIn account, and through that LinkedIn account, I've tried to share a number of stories about avian influenza that I've come across. And I'm continuing to update this as I come across these news stories. So, obviously I'm not getting all of the information that's out there, but I'm trying to share what I can. To access that, you do need a LinkedIn account. If you click on the link, it's going to want you to log in if you're not already logged into LinkedIn. LinkedIn is obviously free, and it doesn't take much to set up an account. They really don't require that much information from you. And after you're done with the class, you're free to disregard it if you want to. But that is a resource available to you if you want to use it to, maybe there's information about your particular community that would be of interest. Or maybe seeing what's going on in other communities would help to spur some ideas about how you can approach the discussion boards. So I hadn't mentioned that previously, but I did want to mention that because as we get into these chapters and these articles that sort of deal with these particular capacities and how they relate to your community, some of these current events might become more applicable. So with that, I think we'll adjourn for now. There will be a second recording focused on supply chain and larger logistics issues that is going to be forthcoming as well. So watch for that. And as always, let me know if you need anything. Until then, have a good rest of your day.